Hey everyone, welcome back. Today I'm going to be talking about SVT, or supraventricular tachycardia. This is something that if you work in EMS or emergency medicine or even critical care at that, you should know about. This is kind of one of our big things that we always learn about, but I think we have kind of a misunderstanding, particularly in EMS. We have a big misunderstanding and a misconception about what SVT is and isn't. So today I'm going to be talking about that and kind of diving a little bit deeper into some of the finer details of that. So stay tuned. Hello and welcome to Past the Scope, the official podcast of Scope Education. This is PharmD for providers who believe learning shouldn't stop at their job title. Join our team as we explore high-impact clinical topics and insights that elevate your care, no matter your scope of practice. The content you are about to hear is based on medical fact, and the opinions of hosts and guests do not represent their respective employers. Remember to always follow your local respective policies and scope of practice. Now sit back, relax, and let's go past the scope. Hey everyone, welcome back. So as I said in the intro, we're going to be talking about SVT today. So what is SVT? Well, SVT is supraventricular tachycardia. Now when I think about that, I like to break the term down. So supra, meaning above, ventricular, above the ventricles. So the rhythm is originating above the ventricles. And tachycardia, well, that's pretty obvious, right? Tachycardia is, by definition, rates greater than 100 beats per minute. So when talking about SVT, a common misconception is that SVT is this one rhythm that we constantly think about, which is that narrow, complex rhythm with no discernible P waves, a rate greater than 150 beats per minute. That's typically what we think about when we think of SVT. But that is, like I said, a big misconception. SVT is actually an umbrella term for a bunch of different rhythms that all originate above the ventricles. And that's what we're going to talk about today. So I wanted to clear that up and kind of just get that out of the way early. So it is a tachydysrhythmia, like I said, above the ventricles or above the bundle of His. And it encompasses regular atrial, irregular atrial, and regular atrioventricular tachycardias. And when I say it's an umbrella term, I mean that it basically encompasses a bunch of different rhythms. So what rhythms does SVT encompass? So it encompasses sinus tachycardia, atrial fibrillation, atrial flutter, focal atrial tachycardia, junctional tachycardia, multifocal atrial tachycardia, or MAT, AV-NRT, which is atrioventricular node reentrant tachycardia, and AVRT, or AV reentrant tachycardia. So those are kind of all the different rhythms that are encompassed under the SVT definition. So you'll commonly hear SVT described as paroxysmal. Well, what does that mean? For people who don't know, or maybe we just need a refresher, paroxysmal means it has an onset and offset. Right? So it has an abrupt onset, it starts, and then it just goes away on its own. We commonly see this with things like runs of ventricular tachycardia, or people have paroxysmal AFib. So you can see an abrupt start and stop to the rhythm. When we think about SVT, the rhythm that we usually think of as SVT is something called AV-NRT. So it's atrioventricular node reentrant tachycardia. So if we break down that word, AV, or atrioventricular, so it's in the AV, it's in the atrium node, so it's in the AV node. The rhythm is originating from the AV node itself. Re-entry, or reentrant, so you have a re-entry rhythm. Basically, it's keeping on this re-entry loop that keeps impulses going through, and tachycardia, so we know what that means. AV-NRT is actually the most common cause of palpitations in patients with structurally normal hearts. So the common example of this is the younger patient who calls 911 or presents to the emergency department with a complaint of palpitations, maybe some shortness of breath. Maybe it started randomly, maybe it started with exercise, or maybe just started during the night and they were woken with some palpitations and shortness of breath. It may start spontaneously or due to something like caffeine, exertion, alcohol, beta agonists, or sympathomimetics. So I think about the patients maybe doing sympathomimetics like Adderall or cocaine, or patients who drink, 2 Bang energies that are 300 milligrams a piece. Maybe that might send someone into SVT. Excessive exertion, especially when you compare it with something like pre-workout, or maybe you shotgunned a Bang and then went to the gym and did a few supersets, and now all of a sudden you have palpitations and shortness of breath and your heart rate's 170. It is more common in women than in men. It's about 75% of this happens in women. So again, this is typically going to be the younger females who are calling for palpitations, shortness of breath, maybe chest pain, maybe syncope. And those are basically some of the signs and symptoms that we present with. So chest pain, palpitations, anxiety is a really common one. This is why we say, anxiety is a diagnosis of exclusion, because there are a lot of things that could be presenting as anxiety. Not to get into the whole anxiety path right now, but that's just a common sign and symptom, or a common thing that we see with patients who present with SVT or AVNRT, is that they have anxiety or they appear anxious. Syncope and near syncope are also common complaints with this. So be sure to get a 12-lead ECG on all of these patients who are near syncope, or pre-syncope as it's also called, or just had a syncopal episode. Really, really important. All right, so what is AVNRT? Well, it's a functional reentry circuit within the AV node itself. So this is not a rhythm that's originating from the SA node. It's not a rhythm that's originating from some ectopic foci within the atrium. It is a rhythm that is generated within the AV node, and by definition, it's a reentry rhythm. Well, what is a reentry rhythm? So reentry typically just means it has a loop. Okay, so it doesn't, like the normal cardiac conduction cycle starts, SA node, intranodal pathways, AV node, bundle of His, down the bundle branches and into the His-Purkinje system, and then it terminates. And then you have another contraction. A reentry rhythm does not follow that normal pathway. So you have a loop, if you will, within a certain structure, whether it's within the AV node or whether it's between the atrium and the ventricle. We'll talk about that later. So this is a functional reentry circuit within the AV node itself. So let's talk about AV node anatomy real quick. So within the AV node, you have two pathways. One is the slow pathway, which has a short effective refractory period. And then you have your fast pathway, which has a long effective refractory period. So you have these two pathways. I like to think of the AV node, and I'll pop a picture up here. The AV node is like this big circle where you have these two pathways running down each side, kind of like a traffic circle. So you have your slow pathway, as you can see, kind of on the left, and your fast pathway on the right. So in normal rhythms, in a normal sinus rhythm, as it's called, you would have impulse coming down from the SA node into the AV node, and then it goes down the slow pathway, which is obviously slow, and the fast pathway. Now, typically the fast pathway is the one that generates an impulse. It's the one that generates an impulse down the bundle of His and into the ventricles and causes a contraction. That fast pathway typically then goes up into the slow pathway and meets the impulse from the slow pathway and terminates it. It terminates it, and then you have no more contraction, no more impulse. Now, like I said before, the fast pathway has a long refractory period. Now, what is a refractory period? And we know that that is the period where the cells cannot generate another impulse, right? So this has a long refractory period versus the slow pathway has a short refractory period, meaning the slow pathway can accept an impulse and generate an impulse before the fast pathway is able to. Now that's the real problem when we look at something like AVNRT, because the impulse goes down both pathways, it gets generated it generates an impulse into the ventricles, and then maybe something terminates it. Or what happens typically is a PAC arrives while the fast pathway is still in that refractory period. So it gets directed down the slow pathway, which delivers an impulse. And then the PAC impulse travels retrograde, or the opposite direction, up the fast pathway when the refractory period ends. The impulse then travels around in the AV node and essentially creates that re-entry pathway. And as you can see, I put the image up there so you can kind of get a better representation of what a re-entry circuit looks like within the AV node. That's typically what's called a slow fast AVNRT, and that's the most common type of AVNRT. That's in about 80 to 90% of patients are going to have that slow fast variant. Now, you may also see some rate-related ST depression, which is also called demand ischemia. You may have heard that term. That's typically within the lateral leads, but it can also be diffuse. You might see some diffuse ST segment depression and then some elevation in AVR. That's called subendocardial ischemia, which essentially the way I explain it is it's a supply and demand mismatch within the heart. So the heart rate is going so fast and it's not pumping enough blood through the coronaries that it can't deliver enough oxygen to meet the demands of the heart. And so that translates into the ECG as ischemia. Now we're going to talk about the types of AVNRT. And I said earlier, you have that slow, fast type of SVT, or AVNRT, which is about 80 to 90% of patients. Then you also have fast, slow, which the impulse gets generated down the fast pathway. And that's not as common. That's in about 10% of patients. And then you have something called slow AVNRT, which is only about 1 to 5% of patients. So that's really uncommon. Slow fast gives you the no discernible P waves, which usually the P waves are there. They're just kind of embedded in the QRS, so you can't see them. But you won't see any P waves, which is where the definition of SVT comes from. And occasionally you'll see some retrograde P waves, but it's more so you'll get retrograde P waves in the next type, which is that fast slow. That's typically when you'll see some retrograde P waves due to that fast pathway having anterograde conduction and the slow pathway having retrograde conduction. The slow, like I said, is rare. It's only about 1 to 5% of patients, and it may appear like a sinus tachycardia, which is kind of tricky, right? Because it'll present with P waves, and so you won't really know, and it may have a rate of 120 or 130. So that sinus tachycardia that you see, or you think you see, may actually be this slow AVNRT. Now, statistically, that's not going to be the case, right? Because I said it's only 1 to 5% of patients. So your best bet is to just assume it's a sinus tachycardia. Now, you may also present with something called QRS alternans, which that is not to be confused with electrical alternans, which is what we typically see in things like a pericardial effusion, which is where you have a normal size QRS voltage and then a small size QRS voltage and then normal, small. Now, you typically with electrical alternans, you will have that kind of slow or low voltage QRS. With QRS alternans, you won't necessarily have that low voltage QRS. You might just have different sizes of QRS, but they won't be small. Now, what's the treatment for AVNRT? This is kind of our bread and butter. This is where, we know this, right? We know this. We know the treatment pathway. We know what ACLS says. We know all the things. So typically, first line is going to be vagal maneuvers. Now, sometimes if these patients know that they have this, they'll try these vagal maneuvers on their own, and sometimes they'll convert themselves. Sometimes they won't. So vagal maneuvers that we typically see is called the valsalva maneuver. So that's having them blow into a syringe and bear down. I find those are hard to explain to patients. When you say, hey, bear down like you're trying to take a poop, it's not really intuitive to people, I find. And so having the 10 cc syringe, it's empty, and they try to blow into it. I usually tell them to try to blow the stopper out from the back of it, which tends to work pretty well. But if we're going to be on top of the evidence and we're going to do the things that are proven to be the most effective, we're going to do what's called the modified valsalva maneuver. And that's where you sit the patient upright, you have them blow into a syringe for 10 seconds, and then you tip their upper body back and their legs straight up. Now that's going to put a lot of pressure into the chest and hopefully stimulate that vagus nerve to give you that vagal response and complete the vagal maneuver. Now the study, I'm not even going to try to pronounce this because I'm going to butcher it, but there's a study in 2021 that showed the modified valsalva was much more effective than your traditional valsalva maneuver. I think it was something like 70%. You can go read the study if you want to get the exact numbers, but I know it was much more effective than the vagal maneuvers. Now, what's your next line of treatment? So let's say we do the vagal maneuver, that doesn't work, which a lot of times it probably won't work. So in the algorithm, our next line is adenosine. Now, what is adenosine? Adenosine is that kind of class 5 antidysrhythmic that doesn't really have a name, doesn't really have a class, but we just kind of lump it into that class 5. So adenosine, essentially what it does is it creates a temporary complete heart block within the AV node. So it blocks conduction through the AV node, which you can see it on the ECG as you might have some P waves marching out and then your ventricular complexes marching out at their rate. So you basically almost have a ventricular standstill with some ventricular complexes showing through. So a complete heart block. But because we know that the half-life of adenosine is so short, that's why you don't get this permanent heart block. So it's inducing a complete heart block to try and reset the a re-entry circuit within the AV node, which explains why adenosine doesn't work to terminate rhythms like atrial fib or atrial flutter or sinus tach, because those are not problems within the AV node itself. All right, so if the problem is not within the AV node itself, adenosine won't work. It won't terminate the rhythm. It'll slow it down so you can maybe see the underlying rhythm, but it won't terminate it. And when it comes to adenosine, we know what ACLS says. ACLS says start with 6 milligrams and then go to 12 and then to 12. However, the evidence doesn't really back that. And I know the AHA just came out with those guidelines and they did not change the starting dose of adenosine, unfortunately. That's kind of one of the things that irked me a little bit about those guidelines, but I'm not going to go down that rabbit hole today. So they still recommend 6 milligrams starting. I will tell you that 12 milligrams has been shown to have significantly higher rates of conversion compared to 6 milligrams. And that was shown in a study by Krug et al. In 2024. Citations will be in the show notes, so you can go look this up for yourself. But adenosine at 12 milligrams as your initial dose was proven to have a significantly higher rate of conversion to 6 milligrams, which is why I was kind of upset and annoyed that the AHA did not include that in their latest guidelines. All right, so we've done vagal maneuvers, we've done adenosine. Let's say you give your 12 and 12 or 6, 12 and 12, whatever you go by, whatever your system allows. Let's say that doesn't work. All right, it doesn't terminate that rhythm. So at this point, we should maybe be thinking, what is this? What else could this be? Is this something else? Did we see an underlying rhythm? If we're pretty sure, we're almost dead sure this is AV-NRT, we have some other options. Now, follow your local protocols, obviously. I'm just telling you what is generally considered kind of the flow of this. Typically, then you go to calcium channel blockers like diltiazem or beta blockers like metoprolol. That's typically kind of the second line treatment for this. Some say DILT should be first line, but that depends kind of on the cardiologist and who's kind of making those decisions. Now, I wanted to jump back real quick to adenosine because I forgot to mention some really important notes about adenosine. So we should be cautious in patients with severe asthma or COPD due to severe bronchospasm, because adenosine blocks some receptors in the lungs and can cause some worsening bronchospasm. So just be aware of that. And adenosine is safe in patients with pre-excitation syndromes or WPW if they don't have AFib or aflutter, but specifically AFib. Okay, so I know a lot of us are taught that we don't give adenosine in patients that have a history of WPW. And once again, follow what your protocols say. My protocols say to avoid it, but it is safe. It's very safe because the problem with the AFib, I'll talk about that later when I talk about some WPW, but just know that adenosine is safe, and that's a pretty wide standard that's pretty widely known in typically the cardiology literature as well. All right, so we've talked about the calcium channel blockers, talked about the beta blockers. Those are options. Those are kind of your second line options. Amiodarone can also be considered, again, depending on your guidelines. Amiodarone is that class 3 potassium channel blocker, but it also does have some calcium channel blocking and beta blocking effects and sodium. So it's kind of a dirty drug. That is an option, but typically that's more of a third line option. So go down your other pathways before you really attempt some amiodarone. And then you always have your good friend, synchronized cardioversion, for those either refractory AV-NRT patients or the patients who are just frankly unstable from AV-NRT. Remember, if it's fast and they're unstable, not saying across the board, but typically it's just try cardioverting them and see what happens. So you always have cardioversion as an option. Either if you've done all these things and you're still symptomatic in AV-NRT, you still have a rate of 170, 180, and they're very symptomatic with palpitations, dizziness, chest pain, just go ahead and cardiovert them. It's safe. It's okay. Maybe consider, and I would say definitely consider, giving some procedural sedation, whatever your protocols say. With cardioversion, I typically go to midazolam. I don't have ketamine as an option, so I typically go just a low dose of midazolam. Typically works really well, at least in my experience. And I'm going to throw up some pictures, some ECG examples of AV-NRT, some of the common types of AV-NRT. All right, so moving on, we're going to talk about what the heck is WPW. This is something that's talked about in paramedic school. I'm sure it's talked about more in probably medical school and other things, but what is WPW? So WPW stands for Wolff-Parkinson-White syndrome. This is a type of pre-excitation syndrome, which means that the ventricles are typically pre-excited. So they're excited and an impulse is generated and an action potential is generated before the standard conduction pathway gets to them. Now, typically this is congenital, right? They're going to have an accessory pathway. So a different electrical pathway typically is between the ventricle and the atrium. And that's typically called the bundle of Kent. And that can conduct impulses in both directions. So it can go from the ventricles to the atrium or the atrium to the ventricles. So that's the bundle of Kent, and that's the typical, accessory pathway with WPW. Now, it can go between either the right atrium and right ventricle or the left atrium and left ventricle. So it can go both ways. Now, remember, this is a rhythm that can be intermittent. You may take an ECG, at noon, and you don't see any delta waves, you don't see any signs of WPW, but then you take an ECG at, 8 o'clock that night and it's presenting on the ECG. So just remember that just because you don't see it immediately doesn't mean it's not there and they don't have a history of it. So like I said, there's two kinds of SVT. Really, there's three, but I'm just going to talk about the two. And you typically have the accessory pathway, like I said, either between the right atrium and right ventricle or the left atrium and left ventricle. So if it's on the left side, so between left atrium and left ventricle, that's called type A WPW. And that's positive delta waves in all the precordial leads, plus a positive R wave in lead V1. And I'll put a picture of that on there. So you'll have these big positive R waves where you're not supposed to have positive R waves in lead V1, with that slurred upstroke of the R wave, which is the delta wave. And then if you're on right-sided, if the AP is on the right side, that's called type B WPW. And that's typically a negative delta wave in V1 and V2. So you'll get more of the typical looking V1 and V2 just with a delta wave. And then the rest of the precordial leads should have a positive or dominant R wave with that delta slur or the delta wave. Now, like I said before, adenosine is generally safe in WPW. And there are two kinds of WPW as well. You have orthodromic and antidromic. I'm going to talk about that a little bit more when I talk about AVRT. But typically orthodromic is more of the safe kind. It's the narrow complex kind. So it is generally safe, except for when the patient has pre-excited atrial fibrillation. And again, we'll talk about that. AVNRT in the presence of WPW is called AVRT, and we'll talk about that next. But that is just the difference when you talk about the definition. Now, most accessory pathways have a short refractory period. They have a much shorter refractory period than the AV node, which allows for faster rates. This is why when you have somebody with WPW, you will typically see some faster rates than you would if they were normally conducted through the AV node. It's important to remember the AV node only allows about 220 impulses per minute, and it kind of squashes all the other impulses. So if the rate is less than 220, this is not a guarantee, but if the rate's less than 220, it's probably not an accessory pathway, but never say never. However, if the rate is over 220, you can know that it's not being generated through the AV node, so you probably do have some type of accessory pathway, or it's a ventricular rhythm. A typical long-term management for these patients is an ablation in the EP lab to kind of try to ablate or burn the foci that's generating kind of the PACs that generate this rhythm. So that's kind of the long-term rhythm, but these patients also may be on some sort of rate control meds like metoprolol long-term. Now, when I said we're going to talk about AVRT, that's what we're going to talk about now. So what is AVRT? I said earlier, that's AV reentrant tachycardia. So this is AV NRT with WPW. Okay, that's pretty much the only difference. Now you have two types. You have orthodromic, which is the anterograde or normal conduction through the AV node or clockwise. This presents as a narrow rhythm. So, and I'll put a picture up here. So you have the electrical pathway that's going from atria through the AV node, and then it's this re-entry circuit that goes down through the ventricles, up the AP, up or the accessory pathway, and into the atrium, and then conducts that impulse. Now that's going to be your near narrow complex WPW. Now, antidromic is the exact opposite. It's retrograde conduction through the AV node or counterclockwise. So this is the rhythm that typically might start in the ventricle and goes up the opposite direction through the AV node in the opposite direction and then atrium back to the ventricles. And because it pre-excites the ventricles sooner than the atrium, that's typically when you get that wide complex rhythm. Again, because we know that if it's ventricular, you have that cell-to-cell conduction, which is typically much slower than your atrial conduction along the pathways. So that's why you have that wide complex rhythm. Now, both have rates typically greater than 200, but you can have 200 to 300. So if you have a rate that's pushing 300, that's almost always going to be an accessory pathway. So just a key point there. Now, standard AV NRT treatments may be used for orthodromic AVRT. So you may use vagal maneuvers, you may use adenosine, you may use some kind of other adjuncts to that because you're not as worried with orthodromic because it's going through the normal pathway. Now, antidromic AVRT, you should avoid things like lidocaine, amiodarone, I made a mistake. So you should avoid your AV nodal blockers, so things like metoprolol, diltiazem, and adenosine with the antidromic or the wide complex AVRT. These should be treated with things like lidocaine, amiodarone too, but I would be careful with amio because remember I said that does have some AV nodal blocking effects. But typically lidocaine or cardioversion is going to be the good treatment here for that kind of wide AVRT. Cardioversion is unfortunately usually required due to the high ventricular rates and the high likelihood of them developing into VF or VT. So like I said, cardioversion is typically required for these patients. All right, so now we're going to talk about what I said earlier, the elusive pre-excited AFib. We'll talk about a little bit about pre-excited atrial flutter too, but primarily we're going to talk about pre-excited AFib because that's the big scary one. So this occurs in about 20% of patients with WPW. They may develop spontaneous AFib, they may have AFib, but this is AFib in the presence of WPW. And like I said, only about 20% of patients with WPW would present with this. Now, AV nodal blockers, including amiodarone, if you want more information on that, watch one of Al-Mehmadi's videos on that, which he lays out perfectly. He hates amiodarone. But if you want to learn more about that, I highly, highly recommend Almehmadi's videos. They're excellently laid out and give a ton of great information. AV nodal blockers, including amiodarone, must be avoided due to the impulses being conducted directly through the accessory pathway. And these patients have a very high likelihood of developing VF and cardiac arrest. Okay, that's kind of where the scare of adenosine with WPW comes from. You don't have to worry as much about AVRT. What really we worry about is that pre-excited AFib, because that if you knock out that normal pathway, that kind of ectopic foci can generate impulses directly to the ventricles, and you might have ventricular rates of 300, maybe even higher than that. VF. This is characterized by, again, like I said, rates of 200 to 300 beats per minute. It's an irregular rhythm, as is typical with AFib. It has a wide QRS with variable QRS morphology. So you might get some wide QRSs and some narrow QRSs, some wide QRSs, some narrow QRSs. That's kind of one of the hallmark signs, plus that extremely high rate that you have pre-excited AFib. The pre-excited A flutter may be normal, but you still get those really, really high rates. So you may not be able to distinguish pre-excited A flutter from like AVRT. Now, the typical and probably the safest treatment for this is just to cardiovert them. Just sedate them and cardiovert them. These patients are very likely to be unstable with those high ventricular rates and the fact that they're in AFib, so they lose that kind of atrial kick from the atria. And if you're going to choose medication, procainamide is the medication of choice due to the fact that it has no AV nodal blocking effects. Now, I don't know about you, but I don't really have access to procainamide. I don't think that's a very commonly used medication, so you're probably just better off sedating and cardioverting these patients, but again, follow all what your local guidelines say. Now, atrial flutter, we're not going to talk about pre-excited A flutter. We're going to talk about just regular old atrial flutter. We're kind of getting away from the pre-excitation and the accessory pathway now. I'm not going to touch on all the rhythms that are encompassed by SVT, just kind of like the big ones that we would see and that we may confuse for AVNRT, and then we may call SVT anyway. So atrial flutter, that's a re-entry rhythm. Again, we're going back to that re-entry rhythm, but it's within the right atrium itself. So you have kind of a re-entry rhythm that's within the right atrium, which causes this kind of sawtooth pattern that we typically see with atrial flutter. The ventricular rates are dependent on the AV conduction ratio. You commonly might hear this as a block. So you'll hear, hey, they have a 3-to-1 block. They have a 2-to-1 block. They have a variable block. So basically all that means is that the AV node is kind of squashing some impulses, some atrial impulses, and it's generating that ventricular impulse. That's all that means. The nice thing about flutter is it has typically a fixed rate depending on the number of flutter waves. So if you have 2 flutter waves in between QRS complexes, you'll have a rate of about 150 beats per minute. If you have 3 flutter waves between complexes, you'll have a rate of 100. And then 4 to 1 or 4 waves in between complexes is about 75. Now, this is pretty consistent, right? This is going to be a very consistent rate with that conduction. Now, if they have variable conduction, you might see, oh, they have a 2 to 1, and then they have a 3 to 1, then they have a 2 to 1, then they have a 4 to 1. That's going to be that variable block or variable conduction. And so you just kind of have to pick like a range similar to you would with AFib. 1 to 1 conduction, that's going to be a rate of 300 beats per minute. That is associated with a lot of instability and can quickly degrade into VF, similar to like that pre-excited AFib, if not corrected. Okay. If the rate is a consistent 150 without variability, so typically sinus tach will have some variability, so you might see rates of 146, 152, 150, 148. But if you have a consistent 150, and it's a rhythm that doesn't really look like sinus tach, and I'll show you an example of it. It doesn't really look like they have discernible P waves, but it's kind of a weird, funky kind of looking rhythm, but it has a consistent rate of 150. Odds are it's either AVNRT or it's this 2 to 1 flutter. It's going to be hard to differentiate between the two. And treating with adenosine is okay, but just know that it won't actually convert the rhythm. But the nice thing is it'll slow that rhythm down enough to allow you to see those flutter waves and make the diagnosis. So that's really important. It's okay. It's safe to use adenosine in flutter. And if it's not AVNRT, then you can just see the underlying rhythm and then treat accordingly down your pathway. Now, the treatment goal for this is similar to, at least in the EMS world, is going to be rate control. It's going to be similar to our goals with AFib. So it's going to be rate control. And that's typically going to be achieved with calcium channel blockers or beta blockers, similar to that kind of second line treatment for AVNRT. Amiodarone is also an option. That's going to give you some rhythm conversion as well, but it's always an option. And of course, if they're unstable, just go ahead and cardiovert them. That's going to be the safest option, and it will fix that, likely. These patients still do have a risk of some thromboemboli or thromboembolus, less of a risk than they do with AFib, but they still do have kind of a risk, so just be aware of that. All right, and I have some examples here, as you can see. Some examples of a 2 to 1 flutter. That's that kind of weird presenting rhythm that doesn't really look like sinus. It doesn't look like kind of that typical SVT that we talk about. So that may be 2 to 1 flutter. And then you give adenosine and you confirm that, oh, this is a flutter. Okay, so that's atrial flutter. All right, lastly, we're going to talk real quick about AFib. AFib's kind of one that we all talk about. We all know what it is. It's that irregular rhythm without discernible P waves. This can be, if it's at a controlled rate, typically rates less than 100, but you can also have rates less than typically like 120 in that controlled rate. AFib with RVRs, AFib with a rapid ventricular response, we know what that is. The big things to note with AFib is you may not be able to differentiate AFib from AVNRT, particularly at rates of 190, 200. So you may end up treating these patients like you would AVNRT and giving them adenosine. But again, like with a flutter, the adenosine won't work. It'll just slow the rate down so you can see the underlying fib and then treat accordingly. Always remember, these patients are at high risk for developing blood clots within the atrium and the ventricles. So these patients are typically going to be on things like Eliquis, Xarelto, or any type of DOAC or direct oral anticoagulants. And that's basically it. Again, this is not a truly deep dive into everything. And obviously there are a lot of rhythms that I did not talk about that I mentioned before. I really wanted to get out there this difference between AVNRT, AVRT, AFib, and AFlutter. And really, I see this gotten wrong so many times. People say it's SVT, and don't get me wrong, I also call it SVT. If I'm talking to the hospital or I'm talking to somebody who maybe isn't in the know, I'm going to refer to it as SVT. But I know, and if I'm talking to some people who are in the know, I'm going to call it AVNRT. Okay, so it's not a requirement that you say, oh, this is AVNRT. If you say it's SVT, most people are going to know the rhythm you're talking about. Just with that background knowledge that SVT is not a rhythm in and of itself. It is a umbrella term for a conglomeration of rhythms. Just knowing the difference is really important, particularly when you're talking about management of them. And like I said, this is something that I see pretty frequently, especially having students. It's a crucial thing to differentiate, okay? Because I've also heard this, people saying, well, the rate's greater than 150, but this person has discernible P waves and this is a rate of 170. Like, this is a sinus tachycardia. This is not AVNRT. Now, are you wrong in saying that's SVT? I mean, it depends on where you kind of sit on that debate. Technically, it is an SVT because it's a supraventricular tachycardia, like AFib, like atrial flutter, like junctional tach. All these things are types of SVTs. However, if you're going to be correct, they're not AVNRT, which is typically, again, the rhythm that we think about when we say SVT. And like I said, I have included the citations in the show notes. Life in the Fast Lane is pretty much the source that I've gotten most of this information from. And a lot of these examples, some of them are mine, but again, Life in the Fast Lane is my cardiology Bible. And I highly, highly recommend, if you are interested in learning more about this topic, please go reference them. They have some great content. And as always, follow us on Apple Podcasts and Spotify. And then go ahead and follow, like, Scope Education on Instagram, Facebook. We will be having some YouTube coming out and probably some TikTok content, so stay tuned for that. And give us some of your content suggestions. And with that, thanks for listening. I'll see you next time.